of deterioration or improvement, and findings are documented on neurological flow sheet. A history of the incident is obtained, including time frame, related past medical history, hypertension, use of anticoagulant drugs, cardiac dysrhythmias, and associated injuries. The patient is prepared for prescribed diagnostic studies, including computed tomography or magnetic resonance imaging, arteriography, and lumbar puncture. The patient is oriented frequently and reassured with verbal and tactile contacts. The ability to speak is assessed, and is aphasia in prison. A consultation by a speech therapist is obtained. Bladder function is assessed. Non-invasive measures are used to encourage voiding in the presence of urinary retention. Voiding pattern is determined, and the incontinent patient is kept clean and dry. Use in dwelling catheters is limited because these promote urinary tract infection. Bowel function is assessed, and dietary intervention and stool softeners or laxative as necessary are used to prevent constipation. Straining at stool or use of enemas is avoided. Fluid and electrolyte balance, intake, output, daily weight, laboratory values is monitored, and maintain adequate enteral or parenteral nutrition is provided as appropriate. Nursing measures are instituted by prevent complications of immobility. In consultation with occupational therapists and physical therapists, a program of positioning and mobility should be initiated as appropriate. Examples of activities include reposition at least every 2 hours, maintaining correct body alignment, supporting joints to prevent flexion and rotation contractures, and providing range of motion exercises. Passive to involve joints, assisted or active to uninvolved joints. Irrigation and lubrication prevent oral mucous membranes and eyes cornea from drying. Prescribed medical therapy is administered to decrease cerebral edema, and antihypertensive or anticoagulant are given as appropriate for etiology. The patient is observed for seizure activity, and drug therapy and safety precautions are initiated. Rehabilitative phase. After the acute phase has subsided, the focus shifts from obtaining baseline measurements of providing necessary life support to more comprehensive rehabilitation efforts. Long-term rehabilitation goals depend on the severity of the initial stroke, the age of the patient, the presence of comorbidities, and other chronic conditions, prior functional status, and ability to perform activities of daily living independently, and the family and social support systems available. To the patient when the patient is medically stable, he or she may be transferred from an acute neurological hospital unit to a rehabilitation setting or subacute setting. Here, the rehabilitation team collaborates with the patient and family to develop a comprehensive care plan based on realistic goals. The rehabilitation program will consist of various types of exercises, including neuromuscular retraining, motor learning and motor control, and functional activities that emphasize relearning or retraining in basic skills required for self-care. This may include instructions in the use of adaptive and supportive devices to facilitate independence in daily tasks. The goal of rehabilitation is to achieve an optimal functional outcome that will allow the patient to be discharged to the least restrictive environment. Ideally, the patient will achieve sufficient independence to return to community living, either independently or with family and community support. All patients' efforts should receive positive reinforcement. Patient communication should be priority. Exercise, proper positioning, and supportive devices to help prevent deformities. Use of footboards is controversial because they may increase plasticity. Quiet rest periods are provided based on the patient's response to activity. The patient should either assist with or perform own personal hygiene and establish independence in other activities of daily living. The rehabilitation team evaluates the patient's ability to feed self and continue to provide internal feeding as necessary. A bowel and bladder retraining program is initiated and both the patient and family receive instruction in its management. Both the patient and family are taught about the therapeutic regimen, activities and rest, diet, and medications, including desired effects and adverse reaction to report. Emotional lability is recognized and explained, and assistance is provided to help the patients deal with outbursts or inappropriate affect. The rehabilitation team assists the patients to accept the deficit and disabilities, maintaining hope while establishing realistic goals. Both the patient and family should participate in available social and financial support groups and services. The patient needs help to accept residual deficits present after 6 months because these may be permanent. Recovery and survival expectations may be influenced by the patient's age and presence of other chronic illness, in addition to early and later response to stroke damage and therapies. Specific rehabilitation efforts are complex and varied. Individualized assessments must be performed and a plan of care designed to achieve the maximum functional outcome based on the nature of the location and the mechanism of the cerebrovascular accident. Prevention. The most important strategy for reducing the incidence of stroke is to control its risk factors, especially hypertension, hyperlipidemia, and tobacco smoking. Patients who have suffered a transient ischemic attack and those with atherosclerotic thickening of the carotid arteries may prevent stroke with medical therapies, example aspirin, lycopene, clopidogrel, or warfarin, or surgical interventions, carotid endarterectomy. Note: thrombolytic therapies and endarterectomy are most likely to prove beneficial in highly specialized treatment centers with demonstrably low complications rates. Ischemic stroke, a stroke due to diminished blood supply to the brain or a particular area of the brain. Example, the lodging of the embolus from the heart is an artery of the brain. Lacunose stroke, a pathological change in the brain caused by diminished or lack of blood flow through one of the brain's small penetrating arteries. When this occurs, there may be no clinical detectable changes in the patient or signs of symptoms of stroke. A group of little strokes may cause progressive dementia. Mini stroke, a colloquial term for a transient ischemic attack. Paralytic stroke, a stroke that produces loss of muscular functions.